let's go back 40 years, 45 years. This hall was not there, imagine. But still, Dr. Alagesan was sitting here with his single crystal transducer and doing M mode. That's how I recall Dr. Alagesan, and I have been following for the last 40, 45 years him, and it's now good to see him with a 3D transducer and real-time imaging of blood flow. Let's see him talking. Thank you, Dr. Alagesan. You can start your session, please.
Thank you, Chairman. The topic is three-dimensional echocardiography, quantification of left ventricle and evaluation of left ventricular function, its usefulness, difficulties, and limitations. My presentation will be for 15 minutes. You can save 10 minutes time. The echo for LV volumes, what do the guidelines say? And what are the methods by which we can measure the LV volumes and the ejection fraction? How we echocardiographically, the mass, LV mass and the shape are useful for analysis of function, left ventricular regional function and desynchrony, left ventricular strain by three-dimensional cardiography, and conclude. So if you go by the guidelines, you can see here, three-dimensional echocardiography is highly recommended for assessing the left ventricular volumes and the ejection fraction, whereas all the others are still in the research stages. This is the echo from which three-dimensional echocardiogram, from which we have got the wireframe image of the left ventricle, from which we can measure the diastolic volume and the systolic volume. We'll go into the details. How echocardiographic volume is very useful, the left ventricular volume. If you see number of diseases, the LV volume and the ejection fraction decides the number, decides what drugs to be given and what intervention to be done, etc. For example, in patients in whom CRT has to be done, the left ventricular ejection fraction should be less than 35%. So in order to avoid unnecessarily putting a CRT in a patient with higher ejection fraction, we have to accurately measure the volume and the ejection fraction. In aortic stenosis, you can see if the ejection fraction is less than 50%, even if the patient is asymptomatic, they have to be, operated, and you have to do a TAVR or a SAVR. So in a number of heart diseases, it is the ejection fraction which is very important for deciding the type of treatment. The left ventricular volumes, initially we were doing this T-Colch method. They are the cube method. This should not be used for assessing the left ventricular volumes and the ejection fraction. The best method is by doing the biplane Simpson method. So all of you have a two-dimensional echocardiographic system. We have to use the two-dimensional echocardiographic method. Preferably, we have to do the apical four-chamber view and the apical two-chamber view. And from this, we can get the biplane end diastolic volume, end systolic volume, calculate the stroke volume and the ejection fraction. Or the best thing is to use the three-dimensional echocardiography. Why? Because the two-dimensional echocardiography, most often the left ventricular apex is not included in the picture, in the echocardiographic picture. The second one is the two-dimensional echocardiogram, we use certain mathematical formula which are not accurate. Whereas in three-dimensional echocardiogram, it is the left ventricular apex is always included in the picture, and the volume is calculated by measuring the volume cells which are present inside the left ventricle. How it is done? Say we have to get a 3D full volume picture, full volume data. So this can be obtained from single beat, 2 beats, 3 beats, up to 7 beats we can use. Higher the number of beats, higher will be the volumes which are obtained obtained in the full volume data set. So preferably, you should use at least, 4 beats. Ask the patient to hold the breath in expiration and then capture the full volume data set by, from 4 beats. So before capturing, we have to identify whether the entire left ventricle is say included in the full volume data set by going to the apical views. We can get a simultaneous two-dimensional echocardiogram in the apical 4-chamber view, apical 2-chamber view, and the apical long axis view, or you can get short axis data sets. So look at the two-dimensional echocardiographic data sets, and when you are convinced that the two-dimensional echocardiographic data set includes the entire left ventricle, and the two-dimensional echocardiographic data set is clear enough to include all the endocardium, then go ahead and capture the full volume data. So this is extremely important, because the better your 2D, better will be the 3D, and better will be the 3D. When the 3D data set is good, then the volume obtained are meaningful. If you have, say, garbage in IT, they say garbage in, garbage out. If they are two-dimensional cardiographic picture and the three-dimensional cardiographic pictures are not good, then your data is not going to be good. From the three-dimensional cardiographic data, we can get a diastolic volume set, and we can mark the, say, the certain points in the interventricular septum, lateral wall, and the left ventricular apex, and immediately the computer will measure the left ventricular volume in diastole. Similarly, we can do the systolic volume. From measuring the systolic volume and the diastolic volume, we can calculate the stroke volume and the ejection fraction by three-dimensional cardiogram. This is what's called the surface rendering of the left ventricle. We can get the left ventricle as a cast. So this cast is the volume. The exact volume can be measured by counting the number of volume cells. You know, say in the TV, they talk about pixels. So similar to that, it is called walk cells, volume cells which are present inside the left ventricle. Without any mathematical mathematical formula, we can measure the left ventricular volume, and the left ventricular apex is always included. Any change in the shape, like local bulging, aneurysm, etc., can be accurately measured if you are going to include that aneurysm in the full volume data set. So this is the MODEC cardiographic volume, which should not be used in centers where we don't have a 3D. We can use the two-dimensional echocardiogram, preferably the biplane method. And if you have a three-dimensional echocardiogram, always use the three-dimensional echocardiographic method for measuring the left ventricular volumes and the ejection fraction. In the two-dimensional echocardiogram, if the two-dimensional echocardiographic, say the endocardium is not clearly made out, then we can inject contrast, which will pass the pulmonary circulation and it will fill the left ventricle. Then you can get a clear delineation of the endocardium, and the volume can be measured accurately from the two-dimensional echocardiogram. This actually, the contrast-enhanced left ventricular volume obtained from the 2D is almost equal to that of the one which is obtained from the three-dimensional echocardiogram. Only thing is, when the endocardium is not clearly seen in the three-dimensional echocardiogram, it is better not to do the volume calculation from the 3D and use the 2D with the contrast as the guideline for measuring the volumes and the ejection fraction. How do you know it is accurate? It has been compared with the gold standard, which is the MRI. And you can see the left ventricular volume measured by the real-time three-dimensional echocardiography correlates excellently with the volume derived from the left ventricular volume. Usually it is slightly, that is a few millimeters lower than the MRI volume. And you can see the R value is about 0.98, which is an excellent correlation. And if you see the regional ones, say this is the interventricular septum, basal portion, mid-ventricular and apical regions, you can see again the correlation of the regional volumes by real-time three-dimensional echocardiogram correlates very well with the MRI data. You can see in the base it is 0.96, in the mid-LV it is 0.97, in the apex it is not so good, 0.81. So this LV volume, which is measured by the three-dimensional echocardiography, the entire LV volume and the regional volume correlates very well with the MRI data. Let us get something about the MRI data. Why the MRI data is so powerful in, say, deciding about the volume? There are few good things about the MRI. That is, in any patient, you can get a clear delineation of the endocardium. And by 2D and also by, MRI, we can exclude the, cardia and the papillary muscle, and we can measure exactly the left ventricular volumes. But one of the drawbacks of the MRI, which they don't talk about much, is it uses the same Simpson formula for measuring the left ventricular volume, which assumes that the left ventricle has got a definite certain shape, or it is made up of certain discs with a definite diameter. So even though it uses the Simpson formula, the measurement is accurate because the endocardial delineation is excellent in almost all the patients. So this again summarizes why 3D is more accurate. It is unaffected by foreshortening. There is no geometrical assumption. It is more accurate and reproducible compared to other imaging modalities. Usually we talk about this one, say eyeballing. Eyeballing is one of the things we still do. So in an experienced person, it may be very near the actual ejection fraction, but you cannot eyeball the left ventricular volumes. You may say eyeball the ventricular ejection fraction. You can identify these three segments are not contracting well, so it is likely to be mildly decreased. Like that, we can come to a conclusion. But exact volume of the left ventricle by eyeballing, we cannot measure. So it is always better to do a two-dimensional echocardiographic or a three-dimensional echocardiographic method for measuring the volumes and the ejection fraction. Now there are artificial intelligence which is coming. So from that, we can measure the left ventricular volume and the left atrium. By the computer, we are able to identify the endocardium, or divide the left ventricle with into different shapes of the left ventricle. So by artificial intelligence, the computer allots some nearest shape to the left ventricular cavity, and from this the left ventricular volume is calculated. This is one of the popular one from the Philips. It has been used in dilated LV, banana-shaped LV, sigmoid septum-shaped with the LV, and normal people. So there is some correlation, but still we have to monitor whether the artificial intelligence is correctly detecting the endocardial border and correctly measuring the left ventricular volume and doing the ejection fraction. So the 2015 guidelines says 2D is the accepted practice for measuring volumes analysis today, with the acknowledgement that 3D is superior. So LV volume or LA volume, whichever volume you want to measure, you should use the two-dimensional echocardiographic method. And if you have a three-dimensional echocardiographic equipment, please use that for getting a better idea about the 3D volumes. Next is about the left ventricular mass and the left ventricular shape. The left ventricular mass, we have got actually the epicardial volume when you are measuring the left ventricular volume and the ejection fraction. We have to, endocardial volume when you are measuring the LV volume and the ejection fraction. So if you draw the line over the epicardium also, then we can get the left ventricular volume, including the epicardium and the myocardium. So subtract the epicardial from the epicardial volume. If you subtract the endocardial volume, left ventricular volume, you will get the left ventricular muscle volume. The muscle volume multiplied by 1.05 will give you the left ventricular muscle mass. Again, this data has been compared very well with the MRI data, and the correlation is excellent because of the same things, that the left ventricular apex is included. The data set again doesn't use any mathematical formula, etc. Because of that, the three-dimensional echocardiographic method of measuring the left ventricular mass is better than the one which is used. But the problem is there are no sufficient studies using even the two-dimensional echocardiographic method or the three-dimensional echocardiographic method of measuring the left ventricular muscle mass. There are a number of studies by using the M-mode echocardiographic method of measuring the muscle mass, And unfortunately, we still use the mode cardiographic method than the 2D or the 3D method for measuring the myocardial mass. The left ventricular regional volume and the function. Say you can divide the left ventricular regional, get the regional volume by dividing the left ventricle into the 17 segments as advised by the American Society of Echocardiography. This is for the entire left ventricle. You can see from the maximum volume when it reaches the minimum volume, that is the maximum ejection has happened. That can be found out by this curve. So this curve can be obtained for all the 16 segments which are mentioned in the, in the basal level, mid-ventricular, and apical level. For all the 16 segments, you can take a curve, and we can actually measure the time taken for the onset to the minimum volume. For each segment, we can do it. And again, this has been correlated very well with the MRI data. The contraction to the minimum volume, both the curves, they can see coincides very much. And this is for the basal, mid-ventricular, and apical segments of the left ventricle. Again, the correlation is excellent. And this correlation is good even in normal people, in patients with dilated cardiomyopathy, and this is a patient with inferior wall infarct. You can see the lateral wall is not contracting well, so correspondingly, the lateral wall shows a delayed contraction in the 3D and also by MRI. So this correlation is excellent with the three-dimensional cardiographic data set. So I'll give you an example. This is a patient with dilated cardiomyopathy. Obviously, this patient has got a left bundle branch block. You can see that rotating movement that indicates the desynchrony of the left ventricle. The rotating movement can be, say, seen even in the apical four-chamber view. Even the three-dimensional echocardiogram, the wireframe image, you can see the rotating type of motion, which is seen in the left ventricular cast. So in this patient, we have measured the time taken from the peak to the lowest value. It can be done for the, say, 16 segments, first 6 segments, 12 segments, or 16 segments. This is the time taken for the segments to reach the minimum volume. So this should be expressed as a percentage of the RR interval. So this is called a Synchrony Index, which was proposed from the King's College London. If it is more than 15, it usually indicates that the patient has got significant dysynchrony, and this patient may benefit from CRT. So, but in a large trials and all that, it is not used that often for analyzing the left ventricular dysynchrony. So this is say regional volume curves before doing the CRT, and you can see after doing the CRT, the volume curves are more aligned. Okay, left ventricular strain. So again, Dr. J.C. Mohan is going to talk next on the left ventricular strain. We use the two-dimensional cardiographic method, which is the most popular one, and he will describe how to get the strain, left ventricular longitudinal strain. So here you can see this is the longitudinal strain, this is the radial strain, circumferential strain, and the area strain. So by a simple method, say from the three-dimensional data set, we can get the longitudinal strain. If I stop the thing, then you can stop it in systole and find out how much is the longitudinal strain. So this is the circumferential radial strain, which is positive, which is in blue color. And this is the circumferential strain, which is again negative. And we can get what is called the area strain, which combines the longitudinal strain and the circumferential strain. So all the strain, by just doing three-dimensional echocardiographic analysis of the data set by the strain software, we can get all the strain, longitudinal strain, circumferential strain, radial strain, area strain. From this, we can calculate the twist and the torsion, and we can easily analyze the type of changes which are happening in a number of diseases. For example, this is in a normal person. You can see, you can get the volumes. You can get the longitudinal strain, which is minus 31, circumferential strain, which is minus 32, and say area strain is minus 37, and radial strain is plus 62%. So immediately by doing a data set, we need not say go on doing it for each views. So the only thing is we have to clearly mark out the endocardium in the three-dimensional echocardiographic data set. So this is in a patient, three-dimensional echocardiographic longitudinal, circumferential area strain and radial strain. So this patient has got an apex which is infarcted. Corresponding to that, the apex shows reduced, all the strains are reduced in the left ventricular apex. But how far this compares with the usual traditional method of two-dimensional strain, it has not come into practice still, and there are a lot of differences between different equipments. It's not yet standardized. So three-dimensional echocardiographic strain is still in the, say, process of evolution. So 3D assessment of left ventricular volumes and function should be done. The only thing is the equipment availability, education and hands-on training, and simplified and highly automated procedures to measure the volumes and function, and further improvement in the spatial and temporal resolution, and one-beat volume with adequate image quality and volume rate. If these are present, the three-dimensional echocardiography will be, say, coming into practice more. The main problem with the three-dimensional echocardiography is the poor image quality. If it is present, then the volume cannot be measured. And then the spatial and the temporal resolution. The volume rate in usual three-dimensional echocardiographic data set is about 20 to 30. Whereas in the two-dimensional echocardiogram, when we are analyzing the strain, the volume rate is almost always more than 50 to almost 100. So the volume rate has to be improved in the three-dimensional echocardiographic data set if it has to become more useful. So three-dimensional echocardiography is a difficult train with many pitfalls, but it is worth the effect, and it is going to be the future standard. Thank you.
Thank you, Dr. Alagesan. That was a wonderful lecture, driving us from a mode to real-time 3D. Thank you very much.